Dr. Itai Pessach's passion for working with children and being a partner in their path towards a healthy life led him to the field of pediatric intensive care. Currently the director of the Edmund and Lily Soffer Children's Hospital, Dr. Pessach is also a renowned researcher and valued mentor to the next generation of doctors. As the COVID-19 pandemic emerged, Dr. Pessach was put in charge of establishing and coordinating the critical care efforts at the Sheba Medical Center. Additionally, he serves on the team consulting the Israeli government in dealing with the COVID-19 crisis. Dr. Pessach enjoys spending quality time with his family and jaunts to the desert. Dr. Pessach has always been a strong proponent for developing relationships with patients and their families as an essential component of clinical care. Talpiot XMed, leadership in healthcare.
What a remarkable evening, ending a really unusual year. And what a year this has been. Maybe the most significant one in our lifetime as clinicians. A year with more questions than answers, a year that have changed the way we provide care. But I'll start with a short story, the story of Avi. Avi is a 64-year-old man, usually quite healthy, slightly overweight. He's married and has 2 daughters and a son, of which he's really, really proud of. He arrived at the Sheba Emergency Department with shortness of breath in early March and was soon diagnosed with COVID-19. He was hospitalized in the first COVID-19 department in Israel at the Sheba Medical Center, but unfortunately, his condition deteriorated quickly and he needed emergent transfer to the ICU. I'll come back to Avi soon. The COVID-19 story of Israel began in early February with the need to prepare for the arrival of the first COVID patients to Israel. These patients were arriving from the Diamond Princess cruise ship, and Sheba, as the city of health of Israel, was the one center that took upon itself to care for them. This was the opening scene in the race to prepare the infrastructure and strategy of treating COVID patients and getting ready to the tidal wave of patients that was approaching. At that point, we had very little data on this new disease and on how to deal with it. A lot was unknown. We focused our efforts on team safety, on isolation, and on distancing. We are used to evidence-based medicine, but there were no evidence. Hence, ingenuity and agility had to come into play. And indeed, we built a high-end, high-tech COVID-19 specific department with innovative technologies, telemedicine, communication, and state-of-the-art equipment that allowed for treating and monitoring our patients from afar and protecting our team members while maintaining a very high level of medical treatment. The Diamond Princess patient came and went, but other, more critical patients started accumulating. These patients deteriorated rapidly and needed a much higher level of care than just one internal medicine department. They basically needed a fully stacked ICU. Avi was amongst these patients. So we had to build a COVID ICU from scratch. As Sheba continued to treat many non-COVID patients, we did not want to use the regular ICUs. So we decided to utilize our emergency hospital located in one of the OBGYN underground parking lots. But how do you maintain a highest level of care, as these patients required, in a parking lot with protective gear and no real ICU infrastructure? Well, there was no textbook or manual for this. This required a lot of very smart, innovative people that see the sky as their limit. Within less than a week, our logistic teams have equipped the parking lot with all that is needed to run a fully operational tele-ICU. Beside all the usual ICU technologies that were brought, command centers were set up with the ability to monitor from afar each patient. Autonomic robots that allow physicians to see and communicate with the teams inside were deployed. High-tech communication and team management systems were used, and even artificial intelligence solutions, automatically monitoring and predicting the patient's clinical status, were implemented. For some of these technologies, this was their first time in clinical use. We got a lot of help from the Israeli high-tech industry, from the IDF and other national authorities. As I said, there was no textbook or manual to guide us. But at the end, the first, and to date the largest and most advanced COVID ICU was built, and the standard of care for COVID ICU patients was set. The bar we raised became the standard for all Israeli hospitals and to many around the globe with whom we shared our knowledge. We even got a call from the White House asking us for the manual on how to build a COVID-19 ICU in a parking lot. Well, we said there isn't one. So Avi was now transferred to our underground high-end ICU and got the best care possible from our dedicated ICU multidisciplinary teams. However, COVID can be a nasty disease, and his condition continued to deteriorate. He was sedated and mechanically ventilated, and as he continued to worsen, he was put on the ECMO, the artificial heart and lung machine, for a very long period. Throughout the time he was there, we tried to communicate with his family. We called and updated them actively twice daily. They really wanted to be at his side, especially in those days. His life was at risk. But we needed to protect them and to protect the teams, so we could not allow them to come over. Some of the patients in the beds next to Avi did not make it. They died, despite heroic efforts by our teams. As many around the globe in countless COVID units, they died without their family members at their side, with only a team member in protective gear holding their hands. This was unacceptable. No one should die alone. We understood at that point that in our race for protection, high tech, and fear of the unknown, the part of human interaction and human experience was slightly left out. This struck me even harder when during my work in the National COVID Advisory Team, I visited all the COVID units around the country, and the one thing the team members raised concern about was not their safety, their working conditions, the long, stressful hours in unbearable protective gear, or their fear of the disease. It was the fear they would not be able to provide the care they wanted to give their patients. They were afraid that in light of the growing numbers and surges of new patients pouring in, they will have to stop caring. Well, miracles do happen. Actually, at Sheba, they happen almost every day. And thanks to the heroic efforts of our COVID ICU team, Avi improved. He was taken off the ECMO and even off the ventilator, and after a short rehabilitation, he went home, more than 3 months after he was initially admitted. He came back to thank us a few weeks later. When we asked him, Avi, what do you remember from your time in the underground ICU? He said, nothing. I only remember this lady on rollerblades that went by and talked to me. Lady on rollerblades? What Avi meant was the InTouch robot, the telecommunication robot that allows the physician to communicate with the patient and team members from afar. The smiling face of the physician in the control room, shown on the robot screen, was the only face Avi could see for more than 2 months. All the other were faceless people in protective gear. This was the lady in rollerblades Avi remembered. It makes you wonder what these times of pandemic do to human interactions and relationships. Everything we know about patient care and communication have changed. As a pediatrician, my strongest tool was always my smile. My ability to soothe an aching child or consult a worried parent was my expression, and my ability to touch. Heck, thinking about this, babies born in March have never actually seen the faces of mostly anyone but their parents. So we changed everything. We let families into the COVID departments to visit regularly. We used telecommunication and virtual reality to allow the patients to communicate with their loved ones and with the teams. We brought in volunteers to assist and spend time with our patients. We printed out faces on our protective gear so patients would know the face behind the mask or visors. And we touched, we smiled, and we hugged as much as we could. We even have a COVID medical clown now, and no one dies alone. As a physician and a human being, I understand now more than ever the importance and meaning of care and compassion. I see what social distancing and fear can cause, and I am sure that in our efforts to overcome this crisis, like other dark times in our past, the key will remain caring for each other. We, the people in the front of this crisis, will have to continue to set the bar high also in this aspect. We have to always remember that we are not health providers. We are caregivers. Thank you very much.
Talpiot XMed, Leadership in Healthcare.